We're going to move on now to the next lecture, which is from Dr. Doris Franke from Germany. And the title of this lecture will be Emergency and Pediatric Transplantation with Contrast Enhanced Ultrasound. Dr. Franke.
So thank you very much, Paul. My talk is about pediatric transplantation. And where do we stand today? Off-label use is still a problem in Europe, and up to now, CEUS in transplanted children is only performed in highly specialized centers up to now, and we have limited experience in pediatric transplantation. There are few publications, and most of them combine adult and pediatric patients, and is not integrated in any of the study protocols. But we think there's really substantial clinical relevance, as stated by the EFZUM position statement on CEUS in pediatric practice last year. So what are indications for contrast in children after transplantation? First of all, what's the most used indication is the vesico-urethral reflux by using contrast-enhanced voiding urosonography. And you can do this after kidney transplantation, and especially if you want to see a leakage of the ureter. But most of the time, we are using the IV application, and especially the most common indications are focal lesions and solid organs, especially the liver, and also post-transplant lymphoproliferative disease, infections or abscesses, infarction or perfusion disturbance, active bleeding, or a relapse of pediatric tumors after transplantation. But also you can use endocavitary CEUS, for example, putting a little drop of contrast and then give it in biliary or other drains to see, for example, abscesses or the biliary system. So at Hannover Medical School, we investigated children after liver, kidney, or combined liver-kidney transplants, after heart transplant, lung, small bowel, and stem cell transplantation. 80% of all the children investigated with CEUS in Hannover were transplanted children. So this is really a major group, where CEUS can really help. And 30% of them had a solid organ transplantation, and 5% were after stem cell transplantation. And as we take a tight indication, the rate of pathological results was high with 86%, and normal in 11%, and inconclusive only in 3%. And a very big advantage of contrast examinations is that you can have them mobile. You can go with the ultrasound machine to the patient, and this was a fifth of all our investigations. So you can go to the intensive care unit, to the bone marrow transplant ward, or to the operating theater and perform your investigation there if a child can't come to you. Side effects, and we'll hear much more later about this. We had one hyperventilation, one adolescent on the second day after liver transplantation who had a strange taste and uncontrollable movements 30 minutes after the investigation, and this vanished completely by itself, and one case of a skin reaction after the examination, which vanished also completely after 90 minutes, and she received some prophylactic antihistaminic treatment. So now we go into cases. And what's really a very good indications and straightforward and easy to perform is after liver transplantation, when you don't have an intrahepatic arterial signal. So this is really an emergency, because the biliary system is perfused only by the artery, and if the artery is blocked, this means that you will have vanishing bile ducts and you will have a liver cirrhosis soon after transplantation. So in this case, you urgently have to go back to operating theater, or you have to relist the patient for a second transplant. And then sometimes, like in this case, of a boy after a full-size liver transplant with cystic fibrosis. You could see here the artery just at the entrance of the liver transplant, but you couldn't see it anymore within the liver, because sometimes you have a very strong portal venous flow, like here, with a little turbulence. So what we do, we did the ultrasound, and you see here the artery coming immediately, and you see here the empty portal venous bed. And now, a few seconds after the artery, now you see the portal vein coming. So you can really easily distinguish these two vessels. Here you have the hepatic artery, and here you have the portal vein. And you can see here the bubbles on the B mode also going into the liver. So once again, with a standing picture, first here you get the hepatic artery, and you see the portal venous bed. You can see here on the B mode is empty. This is 7 seconds after the injection, and then you have some enhancement in the parenchyma, and still only a few bubbles here within the portal venous bed, and then you see here the portal vein coming later, and here the artery again. So you can be definitely sure this hepatic artery was open, and the child did not have to go to operating theatre again. This is another child who received a full liver transplant. He had a Jen syndrome, and he had 2 liver arteries, and one of them developed a pseudoaneurysm, and you can see here that there's a little vessel going into, and when you inject contrast, you see here the hepatic artery, and you see that this pseudoaneurysm is halfly thrombosed already. But what you can also see, and which is quite important, here's the portal vein now coming, that the enhancement within the liver transplant is fine. So this liver gets enough arterial supply, and there's no perfusion deficit. And what you could see here was a little bit of fluid collection around the falciparum ligament. So in this child, you see here the flow within the hepatic pseudoaneurysm, and here the partly thrombosis. Another child, 2 years old, had a biliary revision, and after this very high liver enzymes, and also we knew already before she really had only a tiny portal vein, and this is the artery. So normally it's the other way around. The artery is small and the portal vein is much bigger, and she developed also collaterals at the region of the pancreatic head. So we did a contrast, and what you could see that after this biliary revision, she had a perfusion deficit, which was the reason for this highly elevated liver enzymes. But what you could also see is here, this is the artery, and this is the cause of the portal vein, which was so small that it was difficult to follow in the B mode over the Doppler. And you could see that this is really a very, very little portal vein, which needed a balloon dilatation afterwards. This boy had a liver transplant 12 years ago because of a liver failure of unknown origin, and he came with fever. And already you could see that a biliary problem, a cholangitis, will well be the reason for the fever, and already here you could expect that there was some biliary abscesses within this liver transplant. But when you performed the CEUS, you could see that the region where the abscesses were is much bigger than you could expect in the B mode or with a Doppler. And this is a very good indication also for the contrast-enhanced ultrasonography. And how do you know that this is not a perfusion deficit? It's not really segmental, and it has like fingers going into the liver. And also this boy had other abscesses, like here this splenic abscess, and you could see that this is a relatively fresh abscess, that you have a hyper-enhanced rim around this abscess. So this means there's still active reaction within the spleen. And also you get focal liver lesions after transplantation of other organs, and you want to know, like, to characterize them. What is it? Is it PTLD or what is it? And then, for example, in this case, you could see, okay, this is a focal nodular hyperplasia, and you can follow it up, and you can be relaxed in this patient. And the last case I want to share with you is a little boy from Africa who had sickle cell anemia, and he received a bone marrow transplant. And after this, he had a severe graft versus host disease, which was refractory against steroid treatment in the small bowel. So here you have the gallbladder with some little concrements, but then you already see he had bloody diarrhea, he couldn't eat, he was vomiting, and he was really in a very bad state. And you could see that here you have thickened walls of the small bowel, and also he vomited and he couldn't eat a single thing. So they increased the immunosuppression, and also he received photopheresis, but we wanted to know, like, what's the matter with the small bowel. So now you see the small bowel, and you see that some segments really show an hyper-enhanced wall, like this one, compared to this one in the neighborhood. And also what's more easy with the contrast is to follow, are there any inflammatory stenosis? So here, for example, you see an enhanced wall, and you see, like here, the fluid within the small bowel is going ahead, and then you can much easier follow where is this inflamed bowel wall going to, and how is the peristalsis in this. And for example, here on the standing image, you could see here a stenosis of the small bowel, and you see here the dilated segment orally, and you could see the peristaltic going into, and this is opening but slowly, and here is like some sort of stasis. And here again, the inflamed bowel wall, and then here the stenosis. And how do you know it's inflammatory? It's a very important information for the oncologist. You know it's inflammatory because you still have an hyperenhancement. If this would be fibrotic, you wouldn't have this hyperenhancement anymore in the bowel. So we saw the boy just last week, and he still has 2 stenosis in the small bowel, and they're still inflammatory stenosis. So they're now thinking of altering the immunosuppression. So I want to conclude, CEUS in children has really some obstacles and limitations. If you start, you really need extra training and experience. This means time. It's off-label use still in Europe, and what's not well visible in the B mode, for example air, will not be better with the contrast. Small lesions are a problem because it's difficult to characterize them, but this is the same for all imaging modalities. Multiple lesions is more difficult for ultrasonography because you have to follow them single. When they're in the liver, for example, you have to sometimes get contrast on every single lesion to see really the arterial phase. So you don't get an overall view, and this may make the communication of your results to your colleagues a bit more difficult. You need cooperative patients, but this you can, it's your duty as a pediatrician, and refunding is a problem because it's off-label use, so you have to find some ways. But the advantages and benefits are high, so it's a tool with the possibility of immediately diagnosis and problem solving. You don't need general anesthesia for it, and in all of the more than 300 children we saw, and they were really newborn babies and small children, we did not need sedation in a single infant. You can do it bedside, you can go to the ICU, it's easily repeatable. You can use it IV or intracavitary, and you can use it also with avoiding urosonography. It has no toxicity. It's a dynamic investigation in a close clinical context. It has lower cost than MRI or CT. And what's the most important point is the avoidance of ionized radiation. And there are plenty of new developments. So all in all, we think you really it's a good technique to use, and I thank you for your attention.
Thank you very much, Dr. Franke. I'm going to ask you one question before we move on. How do you choose your dose? How do you give the right dose to the right patient?
Yes, you have to know your ultrasound system. So the ultrasound system, and even like which generation of ultrasound system do you have require a quite different dose. Then it's highly dependent on which probe you are using. The higher the frequency, the higher the dose. Then it is important which mode are you using. There are special different modes of contrast enhanced ultrasonography you can use, and they need a different dosage. And before you start the contrast, you will look with the B mode and the Doppler, and you will see like how well perfused is the lesion, and this also depends your dosage. And for example, a spleen needs much less dosage than a liver, for example. And all this comes together. So for me, I don't fancy these thumb rules very much. So I really know my machine, and I know I do it from my gut, I must summarize.
Okay. Thank you very much, Dr. Franke.